Good afternoon, and thank you for this opportunity to present our plan to create 100,000 green and healthy homes for America's children, homes in which they will grow up healthy and thrive in the classroom, in the workforce, and in life. I'm Ruth Ann Norton. I'm the Executive Director of the Coalition to End Childhood Lead Poisoning and the Green and Healthy Homes Initiative. With me today is Frank DeGiamarino, the former Deputy Director of the Office of Recovery for the White House, and Michael McKnight, Senior Program Officer of the Green and Healthy Homes Initiative. Mr. DeGiamarino is a member of our advisory board. They will join me for questions at the end. For the past 19 years, I and my team have been on nothing short of a mission to break the link between unhealthy housing and unhealthy children in low-income communities. During that time, we have had enormous success at the Coalition. We have built effective national programs, and we have helped to lead the ground efforts in Maryland that have reduced childhood lead poisoning by 98%. But as we listened over time to our clients, we understood that what we were doing wasn't good enough. We understood that just replacing leaded windows and making homes lead safe didn't work alone. That what we needed to do is that we needed to listen and understand that when we shut the door and our vans pulled off, the kids were still sick because of other conditions in their homes, putting their futures at risk and leaving taxpayers to foot the bill because the resources to help them were difficult to obtain. So in response to this, we created the Green and Healthy Homes Initiative. The initiative replaces the fractured systems and with a disciplined and well-coordinated service delivery platform that improves government efficiencies and cost savings while delivering healthy and stable housing, increasing wealth retention for families, and improving outcomes for children. The plight of families in unhealthy housing can best be told through the story of LaQuan Young and her son, Dwayne. When the Young family came to us at the Green and Healthy Homes Initiative, they had been turned down 5 times by programs intended to help them. Dwayne was repeatedly in the hospital for asthma triggered by his home environment, and Mrs. Young found herself on probation at work, where she was an administrative assistant to our chief of police in Baltimore. She was on probation because she was spending more time in the hospital with Dwayne than being at work. With a home with poor insulation and no working furnace, the weatherization program said no, because they had health and safety issues in the home. The lead program, they also said no, because the house was poorly weatherized. The United Way couldn't help them. The Community Foundation turned them down, as did the health department. They found themselves in a catch-22, and the cost to Medicaid for Dwayne's care every year, $48,000. But Mrs. Young's experience is not unlike millions of others in the United States. Families and their needs get lost in the myriad of government programs intended to help repair and stabilize unhealthy and inefficient housing. But they're fraught with conflicting qualifications, rules, and regulations. Families are left to navigate through this system in search of resources to address basic problems in their home, problems that are making their kids sick and depleting their pocketbooks. So when I go to bed at night, what I worry about and what keeps me up are 6 million families who live in unhealthy and inefficient housing, unnecessarily. We talk about problems in the abstract, but it's about people. You can see from this slide that the costs are enormous, billions and billions of dollars. When we say 6 million homes are in substandard conditions, these are families and these are kids who are sick and who are struggling. 3% of what we spend on healthcare in the United States is at the root is unhealthy housing and preventable problems. This is unsustainable for our country. It's certainly unsustainable for these families. Today we've heard a lot of great programs about education, but how in the world do we expect for our kids to learn when there are 14 million school days missed every year simply because of fixable asthma triggers in their home? That's not a cost that we'll pay just this year or for decades. It's a cost for a lifetime for these kids. So in looking at these problems and listening to our clients and what they were facing, we created a common sense approach to solve for the root causes in the home and to remove the barriers to access. Utilizing a program coordinator, or what we call an outcome broker, GHHI aligns government programs, braids existing resources, and helps city to remanage and repurpose those resources, and works with them to identify new opportunities for public and private investment. And the coordinator, that outcome broker, helps to coordinate activities on the ground to improve energy efficiency, lower lead poisoning, asthma, and trip and fall injuries. For the young, it meant new Energy Star appliances and the removal of lead and mold, but it had a greater impact. It had an impact onto the community and on taxpayers. That home cost us $12,000 to repair the problems. If we had done it the old way through siloed programs, it would have cost $16,000, a direct savings of 25%. The Medicaid cost of $48,000 a year had been avoided for Dwayne not returning to the hospital. And the asthma portion, to reduce the asthma, cost $1,500, a 32-to-1 return for Medicaid. And the Youngs, they got a little bit in their pocket too. We've lowered their energy costs, and Mrs. Young is spending more time at work. So in 2009, we took this idea to the White House, and we took it to the Council on Foundations. And in partnership with 28 other foundations around the country, we launched Green and Healthy Homes in 17 cities. And we've found out a lot in our work. We've faced challenges, we've saw barriers, we helped to remove them, but we've learned a lot. And what we know is we're having a significant impact on lowering asthma and hospitalizations, reducing energy costs, having tremendous savings for government up front, and increasing wages of workers who are trained in green and healthy homes. What we have done across urban and rural areas is to create a new way to do business. So how are we going to get there? You see this great map of 50 cities who have self-selected themselves based on the designation criteria that we've created out of our initial sites. Supported also by HUD, who has created a new federal certification program designed directly after the Green and Healthy Homes Initiative, and we've received an endorsement from the U.S. Conference of Mayors urging their 1,100 cities to adopt our platform. These 100,000 units represent less than 10% of all units that will be funded by the U.S. Department of Housing and Urban Development over the period of time to 2015. So we're looking for $12.9 million of growth capital. For that growth capital, we will expand our infrastructure. We will expand our shared data platforms and our human capital to provide the technical assistance needed. And we will fund a robust cost-benefit evaluation that will help us create new financial tools for Medicaid reinvestment and primary prevention and for private sector investment. And we will expand the communications to teach other cities to do this. Our capacity is very strong. We've raised several $100 million to help lead poisoning prevention and healthy homes programs. We've passed over 27 federal, state, and local packages of policies, and we have managed multiple federal and national programs. And we have very strong partners in the White House, the Conference of Mayors, the Council on Foundations, and others. And we are, at Standards of Excellence, nonprofit, having had 19 years as a low-risk auditee. But this is what we will do. With $12.9 million, the U.S. Department of Housing and Urban Development, not us, tell us that we will deliver $432 million in total public savings. But more importantly, what we will do is we will change lives. I began the story of Laquan Young. Today, Laquan Young is no longer an administrative assistant in Baltimore City's police department. She's fulfilling her lifelong dream as a detective in that department. And Dwayne, he hadn't been back to the hospital in 3.5 years, nor has he seen the emergency room. So we're looking at a family who for the first time has a 401k account and a college savings account. What we know is that GHHI works and it delivers. Thank you.
Thank you.
I'm bringing up the good-looking team now.
Oh, great. Thanks very much. That was excellent. And I'm just curious to kind of get a lens on, you know, like we have the kind of individual story of the family that you've highlighted and kind of a lot of the macro picture of the national agencies and funders that are supporting it. And I'm wondering, what does it look like at a city level? You know, what is this, the outcomes broker role, or outcome broker role is a critical one. And I'm thinking going from 15 cities to now 50 plus, you know, what it looks like at a city, just kind of in a snapshot level to just see how that could work and what that role is like, because, well, I'll stop right there. Thanks.
I'm going to start, and I'm sure Michael will help me on this, but let me give you the example of the city of Atlanta. Before Green and Healthy Homes, they had not a single housing program that addressed the health or safety of children. They had housing code, but not other things for asthma and lead. We brought together with an outcome broker and a nonprofit partner in the city of Atlanta, for the first time, 8 different agencies in Atlanta to work together at a table that when they are looking at a house, what they are now doing is doing one assessment that is done by the health department, the housing department, the foster care, the fire department, and the nonprofit partners. There's a comprehensive assessment. All of that data is shared through a shared data platform that lays on top of all of their programs. So that Mrs. Smith, if I'm weatherization, and Michael is the lead hazard control program, we're talking together immediately to deliver one set of services one time. You know, it takes about 20 days of work time, for families to chase down paperwork to do the 5 to 8 applications that they would have to do under the old system. So we save work time there.
Yeah, and so in all of our sites, we create these local learning networks, and so they're able to work through any sort of barriers around collaboration and integration. And if there's policy solutions that they can solve at a local level, they go ahead and implement that. If there are other solutions which may take, you know, federal or regulatory changes, they take that to us, and we work with the Healthy Homes interagency work group that works on those solutions.
Thank you. You note in the map, you show that it's pretty geographically sporadic, both your existing sites and where you are hoping to expand. My question is about your expansion and your strategy around that. It's clear there are a lot of variables to each city, whether it's that type of the potential for the outcome broker, the local construction industry. You know, the variables are really endless. So my question is, what is your decision analysis around choosing a new site, and in addition to the self-selection, really?
Well, number one, that we have now a set of criteria. We've learned a lot of lessons through the initial sites, and so we lay out a criteria that they have to commit, and this is very similar to the HUD certification now. They have to commit to a defined partnership of a working collaborative. They work with us to do a work plan, a resource and gap analysis, so we know what the landscape is. And they work with us to develop an outcome broker who will drive this work. We're looking at cities with high asthma, high lead, high weatherization needs, number one, and cities that do not have a coordinated system in place. So we want to pull together those fractured systems. The reason the Conference of Mayors has endorsed our work is because it saves dollars up front, but it makes systems more efficient. People don't lose their jobs. They're able to do more. And so in this time of contracting budgets, we're actually an extremely attractive program because we help to make systems work better and we deliver more for less. In Baltimore, with the 25% savings, what they used to be able to deliver for 4 houses, they can now do 5.
Can you take a big step back and just explain to me, you go into a new city, you know, let's just say Los Angeles, a nice small one there on the left.
And the mayor's begging us to come, by the way.
Nothing like a red carpet.
In LA.
How, I mean, tell me what step one is. It's not, I mean, everything you do is wonderful. Obviously, the initiative is necessary on a lot of levels. But tell me, and I understand how you connect the dots, you get all the organizations to communicate better, but you said something before is they went into a home and you made that a lot more efficient. And for me, there's a big gap between when you go into the city and when you get into that home. Just, I know we don't have a lot of time, but it's not clear to me exactly what the process is from literally point A to the end game.
Okay, so what happens here is that after the cities have reviewed the criteria and the commitment to follow the process, we will take the agencies, and we do a pretty extensive review of those agencies. The very first thing we're doing is creating a set of shared criteria. So they start to talk the same language between the health department and the housing department, the nonprofit partner. They're all looking at the same assessment. They then have a coordinated set of interventions to work there. The idea of the shared data and the shared outcome and the braiding of those resources, which become very important here. So if you have a weatherization program and you're strongly funded on a weatherization program, but you can't address the asthma program or the lead program, and if you do it incorrectly, you may exacerbate that. We now bring those programs together and teach them how to work together and co-deliver that service.
And we've developed a comprehensive assessment tool that we go out and train those local partners on how to work that in the home, and we bring out assessors that look at how to look at a house more holistically, and we work with those local assessors and agencies.
So everybody's now working off the same script, which makes all of these departments much, much more effective.
Well, there's, one of the other points here is it's not one way, right? There's a set of learnings that have happened across the 15 cities, yet that distilled down into process and best practices. Yet what they're doing in each city is doing what that city needs. And so if there's an inventory to start with, start there. If there's some money that's been focused on a particular program, go over there. And so it's hard to answer that question to say it's exactly this, because it's customized to the city, which was really important to actually the success of the program.
But we do a deep diagnosis with the city of where are their gaps and where are their strengths, and then that's where we bring in new investment. You know, we've brought in utility foundations now in our cities who are not just there for the energy efficiency, but we have worked with them to understand that if they replace the roof, they're also fixing lead paint hazards and asthma, and so they've become engaged in the health side. And with hospital community benefit funds, we're able to help lower their uncompensated care while also improving the ability of their families to get wealth retention because of lower energy costs. You know, what's really interesting about this model is that while it works at the ground level, the idea and the concept that for $1,500 worth of asthma work, we can return a 32-to-1 investment ratio. What's happening at the ground level also has the potential impact to change the way that Medicaid operates in this country. So all of the groundwork being done by these cities is being done locally to improve families and changing federal systems.
Okay, so what I heard from that answer is, and forgive me for using a one-word tag, but it almost appears like you're providing consultancy services to each of these cities. You're helping them understand or better understand the issues that are right in front of them, advising them on how to obviously get all of the relevant organizations within the city to communicate better. But I guess the second part, though, which is still not clear to me, is then how do you get from that part to the home with them?
So there's many ways that families can come into a system. And so what we do is we take all of the different ways that people were going out into individualized systems. What used to happen is somebody would come in for weatherization and they would get weatherization. Now they come in for weatherization and they get looked at for all of the other problems. We get them because of the child's lead hazards in the home, asthma, roofing. We take all of the housing intervention programs now and we put them through the same portal. And what we do for a city is we lower the high energy and high Medicaid use family or high health care family, and we're able to do that at one time rather than extending problems that we've done throughout the cities, that we continue to extend problems because we only take care of a part of a problem because one program is only focused one way. So I hope that makes some sense.
Do we have time?
You have no seconds left.
No seconds left. That's no time.
Thank you.